Hi, everyone, and thank you for joining us for today's webinar titled Guide to Improving Patient Safety in Primary Care Settings by Engaging Patients and Families, brought to you by the AHA's Physician Alliance. To present today's session, we are pleased to have with us Kelly Smith, Senior Director of Quality and Safety Research at MedStart Institute for Quality and Safety. With that, let me turn today's call over to Kelly.
Hi, thanks everybody for joining, and I'm excited to talk to you today about some innovations in patient safety and primary care that we've been working on in collaboration with the Agency for Healthcare Research and Quality that built a guide to improving patient safety in primary care settings by engaging patients and families. This work is funded by the Agency for Healthcare Research and Quality and really sets us up for the goals today to describe and discuss some of the threats to patient safety in primary care settings and how engaging in patients and families in care can help to close some of those gaps. I'd like to let you know that I have no financial conflicts of interest to disclose, and if you do have any questions or comments for me, I would really appreciate it if you sent me an email about your interest in the guide. So the rationale for why the Agency for Healthcare Research and Quality thought a guide to improving patient safety in primary care settings was going to be important was clearly that there was an opportunity to improve safety in primary care, where 5 to 80 safety incidents per 100,000 consultations have been reported in the literature. There were relatively few opportunities in the current literature when we first decided to embark on the guide in 2014 for opportunities to improve safety through patient and family engagement. And many of the existing tools really didn't meet the goals for what is needed in primary care compared to those that were available for hospitals and healthcare systems. The goals of the project for the Agency for Healthcare Research and Quality included wanting ways to engage patients and families in ways that would impact safety and not only quality improvement. Tools were available for practices who had not yet done very much in the area of either patient and family engagement or patient and family engagement or patient safety. So really practices that were starting to build their patient safety journey. The tools that were developed should be based off of a paired tools model, which was a lesson learned from the hospital project to improve quality and safety and care through engagement. And what paired tools means in this case is that if an intervention had tools for a clinician or a practice, there should also be tools for a patient and vice versa. The worst thing that we could do is build a tool for a patient and then not provide supporting materials for clinicians to help them partner with patients to improve safety. Our team has also had very strong experience working with patients and families to improve safety in hospital settings as well as now in primary care. And what our patient partners were telling us is that they wanted the tools to ensure that there was meaningful engagement. So meaningful engagement between the clinical staff and the patient and or family members. The other thing that this particular project did was that we started releasing interventions as they were developed. And so we had a continual process of quality improvement over a 2-year period, and we finally launched the guide back in April of this year. We had several key project deliverables, including an environmental scan, which scanned the literature, both the peer-reviewed literature as well as the gray literature, to identify opportunities for improving safety in primary care through engagement of patients and families. We designed 4 case studies of exemplar practices, including one on open notes, which is a strategy to engage patients and family members with reading their medical notes, team-based care models that encourage patients and families to be engaged as part of the team. Shared decision-making was also one of our key exemplars, including looking at how shared decision-making can be used to improve antibiotic resistance. And we also developed 4 interventions to improve safety through patient and family engagement and pulled that all together in April as a final guide. So in our environmental scan, we identified several threats to patient safety that were similar to what we would normally see in a hospital or a health system, but that also emerged as key leading factors to threats to safety in primary care. These included communication breakdowns, care fragmentation, medication management, so fragmentation of the medication management from the filling to the prescribing to the adherence of the medicines, as well as an emerging literature at the time in 2015 of the opioid problems and the opioid crisis as part of a safety challenge, and also emerging evidence of diagnostic error and threats to diagnosis across the continuum of care. Strategies that we identified to improve those included shared decision-making, strategies that engaged family more robustly in care, having complete and accurate medicine lists and improving medication reconciliation processes, structured communication tools and ways to help patients ask questions and stimulate discussion, as well as team-based models of care. All of these are available in the environmental scan, as well as a comprehensive list of over 700 different strategies and tools that didn't make it as being part of the guide. But all of those are available on the Agency for Healthcare Research and Quality's website. We partnered with our technical expert panel that was comprised of about half of our technical expert panel included patients and family members, as well as leading experts in patient safety, primary care, human factors, usability, health literacy, and our partners from the Agency for Healthcare Research and Quality. We all got together and did a deliberative practice exercise, and we came up with a top 4 list of interventions that could be part of the guide. We ended up establishing 4 evidence-based interventions, and our whole goal was to reduce the complexity, improve usability, enhance the opportunity for adoption of these interventions into practice. The interventions include Be Prepared to Be Engaged, which are strategies to encourage and reinforce patients' preparation and engagement in their healthcare team. Create a Safe Medicine List Together, which applies the brown bag approach for medication reconciliation and develops an accurate medicine list that the patient can take with them. Teach Back, which is really the gateway to shared decision-making and ensures medical information is explained clearly to the patients and families for improved information and improved understanding and adherence to therapies. And the Warm Handoff Plus, which is really moving from transactional to collaborative communication within the clinical encounter. All of these interventions are meant to be initiated within the clinic environment, which really recognizes that the clinic has practice staff, clinicians, and patients as part of the team. And our goal for the development and the implementation of these interventions is really to use the interventions to triangulate the communication amongst the team members, recognizing that sometimes these relationships are influenced by the culture, the community, and the environment, as well as the healthcare system. So our team's challenge was really to make these interventions as usable, adaptable, and adoptable as we possibly could by reducing how complex they were initially and improving their opportunity for adoption into practice. To do this, we partnered with 15 practices from across the country, and they pilot tested the interventions and gave us great feedback, which really reduced the complexity further than we had even thought of doing and made things a little bit more tactical and practical to adopt. I'm going to go through each of the interventions and what it brings and how it can help practices to overcome some of the safety lapses. Our first strategy as part of the guide is Be Prepared to Be Engaged. And this, we would recommend practices start with Be Prepared to Be Engaged because it is one of the more simple and least complex interventions, and it really does support engagement. Another thing that this does is that it reduces the amount of time. Our practices found that it reduced the amount of time that it took to actually get through an encounter with a patient or a family member. It made the practice a little bit more efficient, and it made each encounter a little bit more efficient and a little bit more engaged as the study as we got further into the field test and practices got a little bit more used to using the materials. So the Be Prepared to Be Engaged strategy helps patients and their families prepare for and become more fully engaged in their medical appointments. The goal with Be Prepared is to ask patients and family members to be ready. So be ready with what they want to talk about, any questions that they have to ask of the clinician, and really to speak up about their health goals, preferences, and values in order to make sure that the clinician and the patient can be on the same page. Practices provide patients and family members with a Be Prepared note sheet and encourage them to write down what they want to talk to their clinician about, ask their questions, and write down their health goals. This helps to set the visit agenda and ensure that the patient's questions are answered in a timely manner for the patient and in a way that is sharing in the visit agenda setting process. Why we found that the Be Prepared to Be Engaged approach is important is that there are often significant time pressures in the primary care visit, and sometimes when the primary care practitioner asked about what the biggest threats to patient safety in primary care were, they often told us they just don't have enough time. Adding to the time pressures, patients often arrive at primary care visits unprepared to discuss their concerns or their questions. Or sometimes they forget their questions until the clinician is either left the room or on their way out and really preparing for their next patient. The strategy then aims to help clinicians and patients come to a shared understanding and shared meaning of the appointment, understanding what should be covered. And what we found in our field test, it often helped the clinicians to guide the patients through the visit a little bit more efficiently, and it met the patient's needs for what they really wanted to get out of their clinical visit. One challenge we did identify when we were working with practices is that sometimes patients who may have had low literacy or were illiterate would leave their sheet blank. And what we ended up working with practices on a strategy to overcome that was that the medical assistant or the person who was rooming the patient was able to just sit down with the patient, took 30 seconds to a minute and said, hey, why don't I help you fill this out? Do you have any questions for the doctor today? And that really helped to improve the adoption and uptake of the overall program. The evidence on agenda setting and co-producing an agenda with patients is fairly clear. When patients write down an agenda for their primary care visit, clinicians and patients both feel that the communication during the visit is improved. And with 80% of clinicians in these studies, they wanted the patients to continue to write down their agenda. And what we know about patients and physician communication is that it's often suboptimal. Patients often misunderstand what the clinician is telling them, and more than likely will forget what they've heard about 90% of the time for low literacy patients and about 50% of the time for even those with high health literacy. So enhancing communication is a key strategy to improving safety in primary care, and it will also improve the quality of the care outcomes. The Be Prepared strategy was also touted by physicians as helping to prevent those doorknob questions. The questions that as the clinician is leaving the room or leaving the encounter room, it's, oh, I forgot one more thing. And that helps also in improving the overall clinical experience for both the clinician as well as for the patient. There's several tools as part of this particular strategy, including a poster that's facing for patients and families, the Be Prepared, Be Engaged note sheet, which helps to strategize and helps the patient to really think about what they want to accomplish in the visit and helps to communicate that in a clear way to the clinician, as well as some scripts and some conversation starters for clinicians and practice staff that we really co-produced with our patients and our practice staff as part of this project. The second intervention as part of the guide is the Create a Safe Medicine List Together. And this really comes from that emerging evidence and overwhelming, robust amount of evidence that medication safety across the continuum of care is a leading safety challenge. And this is one clear, clean strategy that we hope that practices will think about adopting that will not only improve the safety of the medicines that your patients are managing and that you're managing with your patients, but it will also enhance your medication reconciliation process. So you might be asking, what is it? The Create a Safe Medicine List strategy is an effort to engage patients and families actively in the participation of developing a complete and accurate medicine list. In the strategy, patients are asked to bring in all the medicines that they have or that they take, including prescribed and over-the-counter medicines, including non-oral medicines such as injections, inhalers, ointments, and drops, as well as medicines that they take only occasionally, like for pain or for pain management or headaches or some similar thing like that. It would also include vitamins and other herbal remedies. Staff within the practice work with the patients to develop that complete and accurate medicine list, and then the clinicians will look at the medicine list and complete medication reconciliation based on the accurate account of what the patient is currently taking. And as you may imagine, this is a very important component of safety for primary care. The CDC says that about 5 to 7% of medicines that are prescribed in the primary care setting are actually an error or result in error. And with 3.2 billion prescriptions prescribed or ordered in the primary care setting, that results in about 160 million medication errors a year, just from the primary care medication process. And this includes those patients who are on 5 or more medicines, or what is considered polypharmacy. About 57% of those medicines aren't needed, are contraindicated, or are not being taken as prescribed. In the primary care setting, what we find in medication safety issues, these include prescribing errors, contraindications, overprescribing, underprescribing, and oftentimes patient adherence because of lack of understanding of either how to take their medicines or why they're taking their medicines. But creating a safe medicine list together can help uncover patients who are unintentionally overdosing by taking both the generic and name brand medicines, which was one of the most common errors that we found from practices that participated in the field test. Oftentimes, the patient was either recently discharged from hospital, and when they came to do medication reconciliation together with using this process, the practice realized that the patient was discharged on maybe the generic brand of the medicine that they were taking for hypertension, but also were continuing to take their name brand medicine, or vice versa. So they were overdosing and all of a sudden very symptomatic because they were having twice the medicine that they needed. That continues to be with one of the most common medication errors that we find, particularly through this process. We also identified opportunities for contraindication with herbal remedies, things that weren't normally in the electronic health record. So practices that have adopted this particular strategy have stayed with it because of the clear number of opportunities for errors that they were revealing. One clinician summed up their experience like this: I think this increases patient safety. The more accurate the list, the better it is for us to be able to manage the patient's health and their medications. If we know exactly what they are taking and how they are taking it, we can implement strategies such as how they should be taking it, or how they should be taking it, or what to avoid, and foods to avoid that might contraindicate with some of the over-the-counter things that they've decided to take. So really it looks at the whole complexity of the patient's medication regimen and brings it into context for everyone on the team. Patients also really enjoyed this because it engaged them with their patients, with their entire practice team, including those extended care team members. In the field test, the individual doing the medication reconciliation ranged anywhere from, or not the reconciliation, but creating the safe medicine list, ranged anywhere from a medical assistant who really just wrote down all of the medicines on the sheet and identified if there were any challenges with the patient's perspective from taking them or if they needed refills, to a pharmacist who really worked with the patient and identified opportunities for improvement, opportunities to de-prescribe medicines, as well as made additional recommendations based on how the patient was feeling, and working with the clinicians on reconciling those medicines. So it really is highly flexible, dependent on the type of staff available to each practice. How it can help is really medication reconciliation is a foundational step in any effort to review and manage medicines for patients. And the Create a Safe Medicine list together results in a clear, complete, and accurate medicine list. We also found that it reduced medication errors within the primary care settings that adopted it. And about 9 of the 15 practices adopted the Create a Safe Medicine list together. So it really did get a lot of experience and expertise, and we got a lot of feedback on how to improve the overall strategy to make it simpler for practices to adopt. It also offers the opportunity to reduce and de-prescribe the number of medicines, which is really one of the key safety strategies for primary care practices, and particularly for those patients on 5 or more medicines. And we found that it also improved the clinician and the patient relationship. For this strategy, it's one of the more complex strategies, and we have multiple opportunities and multiple tools that are available, including patient-facing tools that include a reminder card to bring in all the medicines, the different types of medicines that they should be looking at, as well as strategies. Some of the patients in our field test were a little bit hesitant to bring in their medicines. What they were struggling with is sometimes these medicines were expensive and they were afraid to bring them on the bus with them. Some of them had medicines that required refrigeration. So there were quite a few different workarounds to actually bringing in medicines, including taking a picture of the original medicine or the original box or package, or just to bring in the packaging of the medicine and not bringing in the medicine itself. So there were a lot of different workarounds that we worked with practices and patients to develop and design, and these are all available in the guidance documentation for this particular tool and strategy. Medical assistants were also, while they were used to going through a medicine list in the electronic health record, they weren't always comfortable with reviewing each medicine and asking specific questions about the medicines with the patients. So we created several checklists to help guide those conversations for those patients who also brought in the medicines, as well as to try to improve the reconciliation process for those patients who didn't bring in medicines. So strategies on how to overcome those challenging situations. Clinicians also have some tools here, including overcoming barriers to medicine adherence and some strategies of how to communicate with patients and family members to improve adherence. The fourth intervention as part of the guide, or I'm sorry, the third intervention as part of the guide is teach back. And one of our technical expert panel members, our patient expert panel members, talked about TeachBack as really being the gateway to shared decision-making. And TeachBack was really one of those low-tech, high-touch, interactive, engaging strategies that improves and enhances communication amongst the team members, and including the patient as part of that team. So TeachBack is evidence-based, and it's based in the health literacy interventions. And it promotes patient engagement, patient safety, adherence, and quality of care. So really, TeachBack is an all-in-one communication strategy that if your practice looks to adopt, will improve your patient's experience of care from end to end. With TeachBack, you often ask patients or family members to explain in their own words what they need to know or do. It helps to reinforce that the patient and family member has an understanding of what you said before they leave the encounter, and that will help to improve adherence and understanding after the encounter and lead to improved care. It's a way to confirm that you've explained information clearly and that patients or family members have a clear understanding of what you've told them. So, and oftentimes when you ask patients, do you understand, they generally nod their heads whether they've understood or not. Sometimes this results in a phone call a couple of days later to ask for clarity or to re-explain what you've already told them during the encounter. With TeachBack, if you phrase this in just a little bit differently, just to make sure that we're on the same page, can you tell me in your own words what your next steps are, what I need you to do with this medicine, or can you show me how you use this inhaler at home? That way you can at least ensure that the patient or family member understands the instructions. So why should you do TeachBack? So some of the seminal articles around TeachBack and improving the quality of communication within the physician or within the clinical encounter is that up to 80% of information that's shared during the primary care visit is immediately forgotten by patients. And what TeachBack can do is help to improve that understanding and will enhance the recall. Oftentimes, there's also a 50-50 chance that what is remembered is incorrect. Some of the recent studies on recall particularly show that patients who are lower literacy have a higher vulnerability related to this forgetting or misunderstanding of the information being shared in the clinical encounter. Some of the recent studies suggest that up to 90% of that information is remembered incorrectly for patients with low literacy. So thinking about your patient population, TeachBack is one way or one approach that you can help to support those patients with maybe lower literacy or lower health literacy to better understand what they need to do to improve their health. And so TeachBack is one of those things that improves clarity of communication and improves patient understanding. One clinician who used TeachBack or who started using TeachBack in our field test said, "This is an education for me. I've been a physician for a long time, and I didn't realize a lot of the things that the patients weren't hearing. TeachBack is a wonderful idea. We think we're getting our message across, and obviously we aren't." Another reflection from one of the clinicians in a different practice was that what really helped with TeachBack was that while it took a little while to get going and to rewire their cognitive model of how the clinical encounter was going to progress and proceed, once they got used to doing TeachBack, it actually reduced the amount of time that they were spending, not only in the clinical encounter, but also answering phone calls and answering follow-up questions from patients and family members. So while it took a little bit of time to get comfortable with the process, once they were comfortable, it actually improved the efficiency of the overall practice. There are several tools available, again, for this particular intervention, including an online interactive module that's actually used using game theory to engage you as a practice champion and a practice leader in the process of teach back, asking you questions, and it also provides some key strategies for special populations like pediatric patients as well as elderly patients. Oftentimes we're giving a lot of information during clinical encounters, and that is oftentimes too much for those either in very young or very old. So different strategies for different populations of patients are often needed. The interactive module is about a 10-minute investment of time, and it gives you the complete end-to-end guidance, so you should be ready to pick up and start and try Teach Back after you've completed it. We also have a tips and a role-play scenario guide for clinicians, as well as an in-service education that you can use in your practice to help teach everyone in your practice how to do Teach Back. The final intervention as part of the guide is called the Warm Handoff Plus. And the Warm Handoff Plus is really based off of a warm handoff in the traditional sense was generally between a primary care clinician and a behavioral health clinician to encourage patient adoption and uptake of the behavioral health intervention. We've built on that in really just bringing that communication strategy into the practice during transitions of care. So Warm Handoff Plus is a handoff that is conducted in person between two members of the healthcare team in front of the patient. And if the family is present and it's okay with the patient, in front of the patient and family member. It includes the patient as a member of the team so that he or she can hear what's being discussed about the clinical problem, their current status, the plan of care, and the information about them that they may have provided. This ideally is conducted during the clinical encounter, where it may be the medical assistant or the individual rooming the patient hands off the patient to the clinician in front of the patient. That helps to validate and verify the information that's being shared, and that the patient gives the patient a little bit more of a sense of being part of the team. We also found that the medical assistants or the individuals rooming the patient felt like they were more engaged in the patient's care by providing this communication strategy to their clinicians. One of the goals for doing this is moving from that transactional communication during the clinical encounters into a mode of collaborative communication, which has been demonstrated to improve overall communication in primary care, in hospital-based care, and within teams. So the Warm Handoff Plus engages the patient and family member as a safety check. Communication breakdowns are replete at each of these transactions, either between the medical assistant and the patient, the medical assistant and the clinician and the computer, the doctor and the patient. So all of these, each one of these transactions is really a challenge for the clinical encounter and offers an opportunity to break down. Whereas collaborative communication can engage everyone together just very, very simply. So one of the primary care practices that we had conduct the Warm Handoff Plus and test this in practice had a patient that came in, and during the handoff to the clinician between the medical assistant and the clinician, the medical assistant advised the clinician that the patient was only taking their medicine about half the time. When she finished the rooming process and they did the debrief, the patient actually interrupted and said, "Oh, just to clarify, I take my medicine every morning. I just forget to take it most nights, so I end up taking it only about half the time," rather than having the clinician thinking that they're only taking the medicine, the total dose of medicine every other day, which was what they were thinking, and so they were going to increase the medicine. This way, the clinician and patient were able to collaborate on a strategy to improve medication safety, and having the patient take both doses, both the evening and the morning dose, in the morning so that they would consistently remember to take that. So together, the Warm Handoff Plus reduced the opportunity for overprescribing and improved the strategy on the patient side by being more patient-centered. And that would never have happened unless the clinician or the patient had observed how that transaction was being conducted or communicated to the clinician. So overall, the Warm Handoff Plus approach improves communication both with the patients and among the healthcare team. It makes communication more efficient, and the patients felt that it really was a lot easier to ask questions and communicate as part of the team. It really reduced that barrier and fear of communicating and asking questions. The nursing teams who implemented this said it was really such a good idea, especially getting everybody on the same page. It also improved the clinician and patient relationship, and for those practices that participated in the field tests that are continuing to use the Warm Handoff Plus, have found that it's really empowered the medical assistants and other staff members of the extended care team to be better engaged and feel more connected to the patient. So there are several tools, again, available to help practices adopt, including design guides, because this Warm Handoff Plus does have some complexity with the workflow. Workflow does need to be identified, and opportunities for where and how to do a warm handoff does need to be worked out within each practice. We have a video to explain how you can use warm handoff in practice, and really how much, and it gives a good understanding of just how much time it may take and how difficult or how easy it might be to reorient your practice to adopt a strategy like this. We also have a checklist. So some of our medical assistants who pilot tested this with us were a little bit challenged by, how do I even start this conversation? What are the kinds of things I need to do? And what they really reflate, the physicians related this to having a resident physician report out. It was very similar to a handoff that happens or a report out during rounds in the hospital-based setting. So they really enjoyed it because it brought them back to that collaborative and collegial opportunity for learning and understanding. So overall, we have some additional guidance for how does a practice even get started. So we've identified a 6-step approach to building a robust and sustainable implementation of each one of these interventions as part of the guide. So the first step is identifying and securing leadership support. What we found that having a practice champion and having and obtaining and maintaining leadership buy-in was critical for those practices who successfully completed and implemented and sustained the implementation of the practices and the interventions as part of the guide. Oftentimes, leadership support, if it waned over time, that led to sort of a dissolution of the practice and how engaged the practice themselves was in completing the interventions. So clear leadership buy-in is a key and a must. So oftentimes, many people on this call can really be those champions and leaders for their practices to adopt these strategies. The second step is to really identify what are the practice's goals, values, preferences, where are your safety challenges. And so selecting strategies that will help you overcome some of those safety challenges within your practice is the next step. So ensuring that you have an opportunity to review the materials, understand the rationale behind each one of the strategies, and how it might help your practice is a key way to both keep your leaderships engaged and keep your practice on track to improve safety. Planning. Step 3 is the planning of the implementation, which is identifying the team, setting a reasonable timeline for improvement, determining a standardized implementation process, and opportunities to evaluate and encourage and talk and debrief about adoption. So as you move through the steps, planning is such a key element to improving the sustainability of any intervention, and these are no different. Our fourth step is really designing your intervention. How are you going to implement? Who's going to implement? And what we designed was a really simple 1 and sometimes 1.5 page document asking all the questions you need to ask of your practice in order to successfully adopt each intervention. So we call them Quick Start Implementation Guides, and each one of our interventions has this quick study guide that you can pull out, sit down with your team members, and if you can get through and answer these questions, you'll be on the path to implementation. Because this is a really patient-friendly, patient-facing guide, we encourage making patients aware. So each one of our strategies has an opportunity for a patient to engage in either designing and building their intervention or engaging in the strategy directly. Some are dependent upon the patient, like the Create a Safe Medicine list or the Be Prepared to Be Engaged strategy. Both of those require active engagement by patients and families, but it also requires reinforcement from the clinical team. Reinforcing, thanking patients for bringing in their medicines, making sure that you actually review the medicines if a patient brings them in. That happened to one of our patients in the field test. They brought in all their medicines, and then the practice ran out of time to review them. So it really didn't strengthen that relationship there. So making sure that if you're doing an intervention, providing and making sure that your workflow is sustainable and can adopt and meet the needs of the patient as well as meeting the needs of the practice is important. One of our practices also put the Be Prepared to Be Engaged questions and structures into their patient portal so that if a patient had questions or they wanted to be ready for the clinical visit ahead of time, that's a very activated patient, they would have the opportunity to do that within the patient portal. And of course, a key element of any implementation is evaluate. Recognizing the team's efforts, talking about challenges during huddles, overcoming barriers on an iterative basis. These were key strategies for success. Oftentimes we had practices that did a lot of peer coaching or peer mentoring. Sometimes it was having a nurse coach a physician or coach a resident physician in teach-back, because what we found was sometimes that nurses had a little bit more experience or expertise in the process of teach-back during their training than did resident physicians. So it really created a more robust team-based approach to care. And then, of course, monitoring the impact on patient safety at the practice level, as well as specifically on your intervention. So if you're creating safe medicine lists, perhaps looking at the amount of times that you have accurate medication reconciliation, or looking at the number of times you deprescribe or change or alter a medicine based on the Create a Safe Medicine List Together strategy, or even just simple process measures like how often does a patient bring in their medicines. These are all big wins that need to be celebrated. So all of these materials and guides and guidance information are available on the Agency for Healthcare Research and Quality's website. So please feel free to go download, ask questions. There's an infographic there that helps you, or that could help you talk to your leadership about it and really help to start influencing some change locally. There's a strategy, so if you have if you don't know which strategy to improve or work with, there's some guidelines for each one of them that helps you to map it to consistent metrics that are being done in the environment as well. So please visit the Agency for Healthcare Research and Quality's website, engage with the materials, and feel free to send me an email or ask questions. I'm open and available. We're very excited about this work, and have seen it in action, so we have lots of experience to share. So if there's any questions, I'd be open to discussing a little bit more. Thank you so much.
Yeah, thank you so much, Kelly. If anyone has questions, please chat them into the chat box and we will answer them. Kelly, there is one question I see in there right now from Bradley Dennis, and he asked if your patient population is characterized as an underserved, a high-low literacy group, would that impact your patient engagement strategies, and if so, how?
I think that that's a really phenomenal question. I believe that it will in multiple ways. And what we did, just as a point of orientation, we worked with very diverse practices. Most of our practices had patients and family members who were part of federally qualified health centers. We had 2 inner-city hospital-based practices that had very high numbers of underserved patients or traditionally underserved patients that served the homeless, that served multiple practices. And we also had a few that served more affluent communities as well. So we did get to test these materials and the interventions in a diverse range of practices. What we found for those practices that had, traditionally underserved or high-low literacy, teach-back was a key factor for them. Teach-back and the Creating a Safe Medicine List together were the 2 most adopted strategies of all 4. Both had their challenges, particularly teach-back if you had English as a second language, or not robust access to language lines or translator services. Those oftentimes were a challenge if the clinician and the patient were not both native speakers of the same language, so that was one of the challenges that we found. Advice for that is really just better opportunities for language lines, planning in advance if a patient is scheduled that may need a language line, to have those resources available for the clinician to better engage. With the Be Prepared to Be Engaged strategy, again, the low literacy was a factor quite often. And the practice, we actually worked with the practice medical assistants to see what they thought about the strategy. And the clinicians found it such an important part of their practice that the medical assistants just picked it up and said, hey, what if I did this? I'm asking these questions anyways and entering them into the EHR, or I'm doing, this is part of my workflow because we always ask, why are you here today? They just took a minute, they sat down, they took a look at every patient's Be Prepared to Be Engaged sheet and would help to fill in the ones that weren't filled in. That was really the cue. It wasn't not necessarily saying, hey, I know this patient is a low literacy patient. I should sit down and help. They just started working it as part of their standard of practice. They went through every patient's form before, and if it wasn't filled in, they just said, hey, why are you here today? And made it more of an interactive conversation. So those are the strategies that we really felt that were patient-facing, that really engaged the patient, that had challenges based on both underserved and the low literacy.
Thank you. And I do see there's one other question in the chat box from Paula Griswold, and she asks, what is your strategy for engaging the frontline in testing and commenting on fine-tuning the process for effectiveness in the practice?
It's a great question. Our primary strategy that we really promote and try to support when we do implementations is the huddle, the team huddle. Having some sort of either weekly huddle or during a staff meeting, trying to implement things during regularly scheduled meetings. So many of the practices that we worked with had limited to no resources for quality improvement. We really went to practices that weren't structured for this, and opportunities for engaging them in setting up structure was part of the challenge that we had. So what we identified within the practice is that the practice champions would identify either a weekly meeting or a monthly meeting, and we would work with them to get on the agenda for that meeting. And many of the materials that we've reproduced after our initial field test ended up being presentations or in-services that could be 15 minutes or less. So really trying to reduce the complexity of the intervention to make it easier for practices to do quality improvement, as well as teaching and training, being very, very directed with it, and reducing the amount of just information sharing and making it more practical and tactical was one of our key strategies. But evaluation, engaging the rest of the team in the evaluation was key. So things like process measures. Process measures are perfect for extended care team members to monitor and track. Things like the number of patients coming in with the filled-in with their brown bag, number of patients who complete a be prepared to be engaged sheet or form, or just simple, tally tracking of the number of times you do a Warm Handoff Plus. We had practices that were really great at doing the Warm Handoff Plus for the first 6 or 7 clinical encounters of the day, but it waned over time so that nobody at the end of the day was getting this Warm Handoff Plus. And when I talked with them in June, which was about 7 months after their implementation period ended, they were so excited because they had managed to be able to do it for 3/4 of the day now, or that they do it for sure for the last patient of the day as well. So they're really engaging the whole practice in improvement. It really makes your team a much stronger team. So using huddles, debriefs, shadowing, just things that can be very simply evaluated and tracked are key metrics. Paula's going to keep me on my toes here. So Paula's question was, did you hear from clinicians that their staff, that they improved their enjoyment in their work? So I'll answer these two separately because, yes. So we did hear that there was improved enjoyment, improved engagement from every level of stakeholders, staff members, associates, medical assistants, particularly the medical assistants, because we did really try to lift them up a little bit in this because they can take on a little bit more of the work. They're with the patient FaceTime quite a bit. They're very task-driven, so some of the process measures were easier for them to track and adopt. Clinicians, definitely, they felt more engaged. They felt once they got over the hurdle of adoption and changing the way that they do their traditional behavioral practices, they felt that they were giving better care, which improved their enjoyment and work. The measurable piece is the challenge. Our strategy for this, or our challenge with that we were challenged with for this particular project, is that we weren't allowed to evaluate effectiveness. Our goal was really to look at the feasibility of implementation, how usable was the material, were practices able to adopt this with limited to no technical assistance. So those were our driving challenges for evaluation. We are very interested in seeing measurable changes. Each one of these particular strategies has a very broad and deep evidence base for improvement, but collectively there is limited evidence of how, if you only did be prepared or if you only did teach back, how different would your practice be than if you did all 4 interventions. So we're very interested in evaluating the overall bundled effectiveness of this and are planning on submitting a grant on that in the near future. But it's a great question and one we get asked quite a bit.
All right, wonderful. I don't see any more questions in the queue right now, but if anyone has any last-minute questions they want to type in right now, I will remind everyone that we will have a recording of today's webinar available on our website, which is www.aha.org/physicians. And that should be up by the end of the week, and I do not see any more questions. Let's see. Someone typing in, so we'll just give them 1 minute. Just saying thank you. All right, if we don't have any more questions, I just want to thank everyone for joining us for today's webinar. And with that, that concludes today's webinar. Thank you.
Ladies and gentlemen, that concludes today's presentation. You may disconnect your phone lines, log off your webinars, and thank you for joining us this afternoon.